Okay, good morning all. I welcome all of you in this Diagnostic Day-11. Here today we will discuss Six Sigma and lean concepts in our laboratory medicine. We are conducting this Diagnostic Day, pathology update, microbiology update since the beginning of this year, and we are able to hold all these programs because of the enthusiastic participation of all of you. So before proceeding further, I will unmute one of you. Dr. Yogita, please unmute yourself.
Hello, sir. Good morning.
Good morning, Yogita. Am I clearly audible?
Yes, sir. You're audible.
Can you see this slide of my name?
Yes, sir. I can see it.
Now I have changed the slide. Is this change visible to you?
Yes, sir. Yes, sir.
Okay, great. So now we can proceed with the program. Thank you. I think all of you will agree with me. These days, laboratory medicine has assumed central place in any healthcare organization. What exactly we are doing in our laboratory? We are generating some information. And then this information is applied in a particular situation for better patient outcome. This information may be quantitative. This information may be descriptive. And what is the expectation of clinician from us? They want accurate report, and that accurate report within reasonable time frame. So they have two considerations. One is accuracy, and another is turnaround time. And since ages, we are working very hard to maintain quality in our lab. So this we are doing as per our understanding, as per our knowledge related to quality, but there is a lot of subjectivity. There is a difference in the understanding of concept from person to person, from organization to organization. We are consulting various standards like ISO 9001, ISO 17025, ISO 15189. There are many other standards, ISO 13485, ISO 17020, ISO 17021, ISO 17024, ISO 17029, various CLSI documents. But again, there is a lot of subjectivity. So we were thinking how we can bring objectivity in the system so that we can quantify the quality, which is very important for our laboratory, because in what is the difference between our laboratory and other medical laboratory and other laboratories? In our laboratory, we are testing patient sample only once. In some other laboratories, they may test 5 times, 3 times, but in our laboratory, we are testing only once. Okay, one person is writing voice is not audible, but I checked with Yogita. She was saying that I am clearly audible. So few of you people are attending from different part of the country. There may be some audible issue, audio issue related to one person. So few of you please write in the chat box whether you are able to hear me clearly or not. Rimi Balakrishna is saying I am clearly audible. Okay, right. So that means Sanjeev Garg, you have to check at your level. See why all these things are important. 70% clinical decisions are based on our reports. We want to release error-free report, which is meaningful for clinician, so that they can make correct diagnosis. Correct treatment can be offered to patient, and ultimately, as a laboratory person, we are contributing in the better patient care. So for this, we have to understand certain terminology. See, we will discuss Six Sigma, but we will discuss Six Sigma in relation to our laboratory. So we have to understand certain terminology, like quality assurance. We are telling someone else. you will get quality report. Quality report means you will get accurate report, and that accurate report within reasonable time frame. Now, how we have very good quality control. This quality control doesn't mean only we are running IQC, we are participating in EQUAS. We are taking very good care of our pre-examination and post-examination also. See, 85% errors occur during the pre-examination phase. For this, we have well-documented quality management system, which we have documented as per ISO 15189. In this, we have defined various procedures, how we will carry out various activities, and everyone is following that procedure. So there is no person-to-person variation. If suppose you have multiple laboratories and everywhere you are following 15189, you are following a system, same quality management system, so there will not be significant difference from one laboratory to other laboratory of your organization. And this is very important. And we are maintaining records. Records, these are the evidences with us. We are implementing this 15189 in our laboratory. We are carrying out certain activities. This is the evidence with us. See what happens in our laboratory. We are receiving requests. Then we are carrying out certain activities in our laboratory, and ultimately patient is going with the report. What exactly we are doing? We are collecting sample. If suppose somebody want to know how a particular sample shall be collected, we are advising on that part, how much volume shall be collected, how to collect 24-hour urine sample. Or if we are saying we are not performing this test in our laboratory, we will send to some other laboratory. So it is our responsibility. We are ensuring that laboratory is providing quality services. Then we are testing the samples and we are running controls also. If we are sending some sample to some other laboratory, then it is up to us whether we are releasing report as it is or we are typing on our stationery, whatever it is, we are ensuring there is no transcription error and essential parts of the reports are included. If somebody want to know interpretation on some report, so we are telling what is the interpretation. Post-examination processes, we are taking good care. We are providing correct report, handing a report only to authorized recipient. Whatever report we are formatting, we have a system of formatting. All of you are following the same thing. Now, to carry out these activities in a required manner, we time to time evaluate our processes, sequence of activities, and how we can further improve these activities. If there is some complaint, we are taking good care of that, some corrective action, preventive action, wherever it is required. And time to time, we conduct some meeting, how we can further improve our services. We conduct internal audit. We ask some agencies to conduct audit of our laboratory. Like many of you may be working in NABL, sometimes people say NABL accredited laboratory or some other CAP accredited laboratory, but these are agencies who are providing accreditation as per ISO 15189. Accreditation is ISO 15189 accreditation. So whenever we are using any terminology, we shall be very clear in our mind, we are using correct terminology. So I am telling you these processes so that you can understand where we can apply Six Sigma when we will discuss that. And we are ensuring whatever quality controls we are following, we are taking good care, we are evaluating properly. Now, for all these things, for this evaluation and continual improvement, what is required? Now, you need well-defined organization and well-defined management responsibility. If somebody is lab director, you are following ethical principles, you have legal entity, organization is actively involved in the laboratory activities. We are taking good care of service agreement. There is an agreement between laboratory and patient. They will get correct report and that correct report within reasonable time frame. For this, you are defining your quality management system. Document means any meaningful information on any suitable medium. We are taking good care of your documents, how you are preparing, you have a well-defined system. Whatever records you are generating, evidence of implementation of activity, you are maintaining in such a manner, they are easily retrievable and retrievable in legible manner. Now for this, what is required? People who are working in your laboratory, they are qualified and well trained. Environmental conditions of the laboratory, they are well maintained. Temperature, humidity, no excess dust is there, no electromagnetic interference. Cleanliness is maintained, appropriate biomedical waste guidelines are followed. Equipment, reagent, consumables, equipments you are maintaining, you have a system, what you will check daily, what you will check weekly, reagents, how you are receiving reagent, what all you are checking at the time of receiving reagent. You are carrying out lot acceptance testing. Consumables also are checking, these are of good quality. You are evaluating your vendors who are supplying you different reagents, machines, or who are providing you services. Then laboratory information system, you're taking good care, you're generating so much information. You have to maintain laboratory information system in such a way data is retrievable whenever it is required, and it is accessible only to authorized persons. You are restricting access to unauthorized persons. So these are the different activities which all of us are performing in our laboratory. And if you see what exactly we are doing, sequence of activities, you are receiving requests, you are collecting samples, you are transporting samples, then someone in the laboratory receiving those samples, then they are carrying out certain processing, maybe aliquot formation, and these different aliquots, these are transported to different sections of the laboratory based on type of test required. Then these are registered in the respective sections in the LIS, and tests are performed. These are interpreted with the clinical findings with control results, and then the report is generated. If there is any critical result which require immediate therapeutic intervention, this is informed to clinician or patient immediately. And these activities are being performed in every laboratory. Now, why we say this laboratory is good, this laboratory is not so good? Somebody is saying screen is small, but from my side, this is full screen. So I cannot make screen bigger than this. I think if some of you is facing problem, so you have to check settings in your laptop. I think it is okay with all of you. Dr. Farah, please unmute yourself.
Yes, sir.
Dr. Farah, is this screen okay?
Yes, sir. It's okay.
Okay. So now tell me, as we were discussing, every laboratory is following the same procedure, the same sequence of steps. Then why we say some laboratory is good, some laboratory is not so good? What is the difference, or where is the difference?
Sir, I think while we are following it, some laboratories are following it, and as they are following it, they are documenting it, and time to time, they're also evaluating it. And when they find any gaps while doing their works, they try to improve that by correcting the problems and find out it in a proactive way. And other laboratories may have the process, but maybe they are not following up well.
Dr. Farah, where are you from?
Sir, I'm from Bangladesh.
Okay, right. Very good. Excellent. Now see the next slide. As Dr. Farah was saying, in a good laboratory, things are well maintained. Laboratory has well-defined procedures at each step. They also have procedure to check any deficiency at each step. When you have this type of system, you can detect an error before it is happening in the patient sample. This we have to develop. And at each step, we can use Six Sigma also. With Six Sigma, we can see whether we are improving in that particular area or not. How we can do that, we will discuss later. But before that, I am telling you, this quality system is important. And what are the areas where we can use this knowledge? See, Six Sigma is a powerful tool. Sometimes we want to check quality of the method which we are using, or suppose 3-4 companies, they are providing us reagent for glucose. We want to check which is more suitable to us, or we want to compare equipment. 3 companies are approaching you. They are saying our equipment is good. We can use this knowledge in the equipment comparison also. We can optimize our QC procedures. If suppose at present we are running 2-level control twice a day, and we are working at very high Six Sigma level, suppose 5.6, 5.7, we can come down from 2-level QC twice a day to 2-level QC in the morning, 1-level QC in the evening, like that, from 4 times to 3 times. And still, if our Six Sigma is maintained, we can further reduce QC procedures. And we can further reduce this number of QCs per day. And we have documented evidence with us in the form of Six Sigma. Our quality is not compromised. How frequently we need to run, how many controls we need to run, how many rules shall be applied, we can decide that. 2 things are very important: process variation and process outcome. In both cases, we use Six Sigma. And what is the difference in the application? And what is the meaning of this process variation and process outcome? That we will discuss. And we can also check the lab performance over a period of time. You can compare different laboratories also. Problem is, if we try to carry out all these things, there is a lot of subjectivity. And we want objectivity. Whatever we are saying, we have some data with us. And this is a common saying, people believe in God. For all other things, they want data to believe. Yes, Gunjan, please unmute yourself. Okay. So now we will discuss this sigma. What is sigma? Sigma is a Greek symbol for standard deviation. Because in this Six Sigma, we use standard deviation. So we are using this symbol sigma. Matrix means, metrology means study of measurement. Matrix means some measurement. In this, we are using some measurements. And this measurement is standard deviation. So we say sigma matrix. One way is we count how many errors are happening. Suppose you are receiving 100 test requests from Delhi. In the month, you will receive 3,000. And you are finding out of these 3,000, in 10 test request form, history is not mentioned. So now 10 per 1,000, 10 defects per 1,000, you are converting that to defect per million opportunity. To convert 1,000 into million, what you are doing, you are multiplying 1,000 into 1,000. Similarly, you are multiplying 10 with the 1,000. So 10 per 1,000 will become how much? 10,000 per million. And there is a scale you will find on net or in some textbook where you can convert this defect per million opportunity into Six Sigma. And we will discuss that. In broader terms, we say Six Sigma means 3.2 defects per million opportunity. 5 Sigma means 233 defects per million opportunity. So like that, for fractions also, there is a scale. You can relate with the sigma matrix and you can note down that. This is process outcome. As doctor has to fill test request form and you are finding out of 1,000, in 10, the forms are not filled. Now you are converting that to million opportunity and you're deciding, okay, probably it is somewhere between, suppose it is between 3.5 to 4 sigma. So like that. And if suppose at a later stage, you are calculating, now it is 5.1 sigma. Oh, there is improvement. So now data is speaking, there is improvement. From 3.8, it has reached to 5.1. As close it is to 6, better the situation is. Now see in this table. 6 sigma means 3.4 defect per million opportunity. 5 sigma means 233 defects per million opportunity. 4 sigma means 6210. 3, 66807. 2, 308538. And 1 sigma, 6,91,462. And remember one thing. If it is 6210, what is the meaning of this? Out of 1 million, that means out of 10 lakhs, there are 6,200 10 defects. Now, this figure is looking very large, but out of 100, it is only 0.6. So you can say correctness is 99.4%. Now it is looking very impressive. 66807 means out of 100, 6.7. 93.3%. So now if out of 100 opportunities, you are correct 94 times, so what will be your impression? Yes, Aditi Bansal, please unmute yourself. Dr. Krishan Priya R, please unmute yourself. Or Parveen Nair.
Hello, sir.
Yes, Dr. Krishan Priya.
Oh, yes, sir. It means that it's the previous one is better, but it's 90.
What I am asking, if suppose you are collecting samples in the sample collection area, and out of 100 attempts of venipuncture, you are failing in 6 cases. What will be your thought? It is very bad, or it is reasonably good, or it is very good,
It's
or your some
reasonably
technical
good.
staff is failing in 6 instances out of 100 possibilities. What will be your impression?
It's reasonably good, sir.
It is reasonably good, right? And if it is right 99 times, or you can say out of 200, the person is not able to correct sample properly in one situation, you're saying this is very good. Am I right?
Yes, sir. Yes, sir.
So, because when we go by these figures, 6210, 233, these are looking very high figures, right? So many errors, this is not acceptable. But if you relate these to your practical situation, then you are finding these are not too many, right?
Yes, sir.
And most of the industries, including our laboratory, in most of the situation, they are working close to 3 sigma, not 6 sigma. They are working close to 3 sigma. Many laboratories may be less than 3 sigma, but most of the laboratories close to 3 sigma. And we have to improve from this 3 to towards 6. So now think over this. We will start in only 1 minute. Think over this table. This correlation between this data and our laboratory is very important. Only then we will be able to appreciate this concept of 6 sigma. Now we have to understand certain terms which we will be using now. What is bias? Bias is the difference between true value and your result. Bias we calculate from equals. Whatever group mean we get, we consider that as reference value. our value should be as close to this group mean as possible. So now how this bias is calculated? Lab result minus group mean divided by group mean into 100. So we get bias percentage. This we are getting from EQUAS. Then variation in our day-to-day result. For this, we calculate CV% from our internal quality control. First, we discussed process outcome. How much defects are there out of the given possibilities. Now we are shifting towards, that was process outcome. Now we are shifting our attention towards process variation. So for that, we have to understand these terms, bias and CV%. So I'm not discussing something very complicated, or whatever is complicated, I am going slowly and in a simple manner so that you can understand. Then at a later stage, with this foundation, we will discuss certain things which are little more complicated at some later stage. See, bias we are calculating based on our EQUAS report. And if you are participating in EQUAS, then you will know you are getting group mean in your EQUAS report. Lab result is your value. Then group mean you are getting from EQUAS report. Lab result minus group mean divided by group mean into 100. That is bias percentage. And CV% you are calculating from your IQC data. Same sample you are running daily. And this is applicable only to quantitative results because you are getting some discrete value only in quantitative results. Standard deviation divided by lab mean into 100. Now you have two terms and these two values with you. One is bias percentage and another is CV percentage. So now with this framework, we are moving towards Six Sigma. So we said we can apply Six Sigma in two types of situation. One is process outcome and another is process variation. Process outcome, how many puncture failure out of given possibilities, how many typing error out of given possibilities, like that, or how many patients without completely filled test request from out of given possibilities. So like that, we can imagine any situation and we can apply Six Sigma there, process outcome. In that, what we have to do, these two situations where we can apply Six Sigma, what we have to do in process outcome, we have to find out. In 1 month, there were these many possibilities. Out of these, how many times we were not able to fulfill the requirement. Suppose turnaround time. We are releasing 100 reports every day, 3,000 per month. And in two situations, we were not able to follow the turnaround time. So out of 3,000, two situations. Then out of 10 million, how many situations and what is the Six Sigma? So like that, number of times we were not able to fulfill the requirement. These are converted to defect per million opportunity. And then with a table given in the internet, or if you feed in the Google defects 3,246 out of 10 million, convert this to Six Sigma, so that will automatically convert for you. or you can develop some formula in the Excel. All of you are expert in computer. It is up to you how you are following that. But what we are discussing here, a conceptual understanding. You can apply to any situation: pre-examination, examination, post-examination, any possibility. The number of times reports are handed over to wrong person. If somebody asking, give me the report of Madhu, and you are handing over the report of Madhu Chawla, and that may be Madhu Quatra, so you have to ask full name and you have to check that the person is authorized recipient of that report. Number of IQC errors per month out of possible situations. Number of EQUAS errors. Suppose every month you are participating in EQUAS for 50 parameters, and out of that there is 1 or 2 outlier. So you can convert that into 6 sigma, or in 1 year, 600. How many outliers? You can convert that into 6 sigma. You can use any situation. Then you can compare. Oh, 2014, this was our EQUAS performance. 2015, this was our EQUAS performance. From 4.6, it is increased to 5.1. So that means we have improved a lot. So you can present this data before your management also. This is useful tool, and you have to think where we can apply this tool. So we were discussing process outcome, number of defects converted to per million opportunity, and then sigma matrix. Now, process variation for quantitative. Total error allowable. Total error allowable you get from the data from WestGuard website or maybe some other source. There is guidelines by RECOS where you get this total error allowable. You can go to WestGuard website. There is one Really Bank, clear guidelines also. You can use any of these. So you get total error allowable. Total error allowable you are calculating from your data. No, total error allowable you are getting in the literature. This bias percentage you're getting from your EQUAS, as we discussed. CV% you're getting from your IQC, as we discussed. So with this, you are able to calculate your sigma matrix. So you can calculate for different analytes, and you can have an impression how we are performing in different analytes. For the same analyte, you can make a table, January, February, March, April, how your performance related to that analyte is progressing over a period of time, over the month in a particular area, or over a period of 5-6 years in different years, how it is progressing. This sigma matrix, whether you are improving in that particular analyte or not, so you will get the information. Now, minimum acceptable performance is 3 sigma. World-class performance is 6 sigma. So now suppose at present, you are working at a level of 4.5. Then you can decide minimum acceptable performance for your laboratory. For us, we are deciding it should not decrease beyond 4 for any parameter. It should be at least 4. This is up to you. I have provided you one data, but based on your present performance, you have to define your minimum acceptable performance. So now, suppose you are starting application of the 6 sigma in your laboratory, and you are saying minimum acceptable performance is 3 sigma. So you are calculating 6 sigma for all the parameters, and then you are deciding where it is less than 3 sigma. Okay. Now suppose for 3-4 parameters is less than 3 sigma. How to decide? how to further move, how we can improve in this situation. So that we will discuss. So for that, what we do, we use another tool, Quality Goal Index, CGI, QGI, Quality Goal Index. What is this? Bias divided by 1.5 into CV. And how it is interpreted? Less than 0.8 means CV is high. That is why this is giving you low value. It is imprecision. More than 1.2, that means bias has increased. That is why you are getting high value, more than 1.2. 0.8 to 1.2, that means there is imprecision as well as inaccuracy. Now you will say, then what is the situation left? It will be either less than 0.8 or more than 1.2 or 0.8 to 1.2. There is no other possibility. See, bias you get from your equals. Bias is difference between true value or whatever reference value you are using, we get from equals group mean. The difference between your result and group mean divided by group mean into 100. That is bias percentage. Now that we were discussing, if suppose bias has increased, CV is also increased, then and there is no other possibility. But we are applying this. You have to remember, we are applying this tool only in those situations where 6 sigma is less than 3, or where the 6 sigma is less than minimum acceptable performance. So we are not using this QGI if our 6 sigma is 5.1 or 5.4. We are using only when the 6 sigma is less than 3. This you have to remember. So we are using in unacceptable situation only. So whatever calculation we are getting, we are proceeding accordingly. So now see. Don't you think it is looking little complicated? Yes, Aditi, can you hear me? Yes, Bonnie Thomas, please unmute yourself. Shankri Shanoy, please unmute yourself.
Yes, sir.
Yes, Shankri, am I clearly audible?
Yes, sir.
Tell me one thing. Don't you think this table is looking little complicated?
Complicated, sir. Yeah, complicated.
I was showing for this purpose only, so that you understand what are the complicated things we are going to discuss in the next session. So we are not discussing this here. Now see, on this x-axis, we have written observed imprecision, percentage CV. See, as this percentage CV is decreasing, so from periphery, this number is moving towards the center. If suppose we are working at 2 sigma level, then we will be in the poor to unacceptable. But if it is between, if it is around 5 sigma, So we are near excellent, or if it is more than 5 sigma, we are in the world class zone. Am I right, Shankari?
Yes, sir. Yes, sir.
So, but we are not discussing this here in detail because otherwise it will be difficult for all of you to concentrate. We are discussing only simple things here, but all these things will be discussed in the future lectures.
Okay.
Now see how we can apply this 6 sigma. See, we performed one study in 2019, 10 parameters of biochemistry. We evaluated for 6 months. This is percentage CV of different parameters. So sometimes suppose it is 3.6 per albumin, you are saying CV has increased. In some cases, it is 2.1, 2.0. So this is how generally we evaluate our laboratory data. So this is percentage CV. We also calculated for the same period bias percentage also. Now, if you see percentage CV in the month of June is 3.6 and the month of April it is 2.0. So CV is more in June, you will say there is some imprecision in the month of June as compared to April. But now, bias percentage, in the month of April it is 2.9 and the June it is 0.9. So in our IQC, performance is better in April, but in our EQUAS, performance is better in our June situation. So now how to decide whether some action is required or not? Yes, Anjan Trivedi, our regular participant. I think, Anjan, you should get one prize for attending maximum programs. Right? Because when I conduct some program, I always find your name. You should get a prize for attending maximum programs. And now,
even though I got slightly late, but then I joined, sir.
No, very good. So now, don't you think this situation is little critical? If we analyze with the help of IQC, then performance in the June is better, performance in the April is better. If we use EQUAS, the performance in the June is better. Right? Yes, Anjan. I think he has muted himself again. Anjan, keep yourself unmuted, please. So now, how to decide how we are performing in a particular analyte? See, what is the purpose of running control? What is the purpose of participating in EQUAS? We want to detect an error before it is reflected in the patient samples. So our system should be as strong as possible, as robust as possible. So, but here the situation is a little confusing. So now, what we can do? We have to see. See, in this CV percentage, so we calculated average also of the last 6 months. Similarly, in bias percentage, we calculated the average. Now see, now we calculated sigma matrix and quality goal index. So how we calculated sigma matrix? Total error allowable minus bias percentage divided by CV percentage. So we have both these values decided from our IQC and EQUAS. right? Now, although here we calculated QGI for all these cases, but it is applicable only for those which are less than 6 sigma. So we calculated 6 sigma for all the parameters. Now you will find for certain parameters like creatinine, glucose, potassium, and total protein, it is less than 3. So that means these analytes are not performing well. So for this, we calculated quality goal index also. Because if it is less than 0.8, there is imprecision. If it is more than 1.2, there is inaccuracy. And if it is 0.8 to 1.2, both are operating. In 4 parameters, as we discussed, we were performing below 3 sigma level. So as we discussed, what is the cause? If it is in case of creatinine 2.3, 0.6, there is imprecision. In case of glucose, imprecision as well as inaccuracy. In different analytes where it was less than 3, so these were the reasons. We can take decision accordingly. What are the reasons for this inaccuracy? What are the reasons for this imprecision? So this may vary from laboratory to laboratory, and we have to decide and we have to take action, and we have to document that action and correct this, calculate 6 sigma again next month and see what is happening. With this sigma matrix, we can reduce the number of control rules. We can reduce the frequency of controls. Because if we are working at 6 sigma or 5 sigma, that means errors are few. And if we reduce the number of controls, if we reduce the frequency of controls, and 6 sigma is maintained, so that means there is no compromise in the quality. So that way we can save some money, and we have objective evidence to say see, Rohita, for pre-analytical errors, qualitative, we have to do 6 sigma process outcome. There is no process variation. In case of quantitative parameter, it is process variation. You have to apply 6 sigma, but in a different way. So that is why I said today we will discuss only simple things. So we are not discussing any complicated things. And listen carefully, you will find answer for all queries. What I am trying to say, if you start following 6 sigma, start calculating, so you have objective evidence with you regarding the quality of a particular situation in your laboratory, and you can take decision accordingly. See, one is systematic error. Systemic error means it is affecting your all results. Daily you are running control, so it is affecting in every cycle. What may be the reason? Some change in the reagent, some change in the control. Suppose control is not reconstituted properly, or a reagent is not stored properly. Then that means there is deterioration, though it will not affect your single test result. It will affect your all result. Or weekly or monthly maintenance is due, something has happened, suppose some little clot in the tube, and it is slightly affecting your all results. You are getting results all on one side of the mean, something like that. Some change in the lot of calibrator. You are reconstituting some calibrator. It is not reconstituted properly. Or some maintenance service, or some lamp change is there, or lamp is deteriorating, so it is affecting your all result. Reagent stability, sometimes what happens, these are not stored properly, or date of reconstitution of the control. This also you see sometimes when we are reconstituting, you are finding after that there is deterioration of it is not stored properly. Suppose you are reconstituting a control and preparing 10 aliquots. And these are not somebody is taking out, bringing that to room temperature, whole box, and then taking out one aliquot and running that. After 2-3 hours, they are now keeping the box again in the refrigerator. There is repeated freezing and thawing. For 5 days, the results are okay. But suddenly, after that, you start getting trend. You're getting lower values after 5 days. And when you are reconstituted again it is okay for 5 days, then there is problem. So that means certain thing is affecting your control after 5 days. And when you are investigating, you are finding this is the reason. So you have to develop a little bit Sherlock Holmes within you to take appropriate decision in any situation. Or some random error. In this control you have brought to room temperature, but it is not mixed properly. Some bubble is there, which you have aspirated. Shelf life of reconstituted control, electronic fluctuation, or some instrumental error, or some pipetting error. There is some small clot which has affected your one result, and then after this test, a reagent washing, etc., so that clot goes away and there is some problem. So that way, you have to see what are the possibilities. You have to use your experience related to a particular field, because these things you will not get in one book. I have read from this Tits or Henry or some other reference, and now I know all the things. This we learn when we are discussing with each other, when we are attending some meeting, conference, and we are participating in various meetings and attending what is the experience of other speakers. Like in this program, I'm able to see one very experienced person. And this is privilege for me, that person like him is attending our program. Because most of the time, we see him delivering some talk in some national forum or international forum. Dr. Ashok Ratan is with us. So he is very experienced person, very knowledgeable person. So we can apply this Six Sigma in two situations. One is process outcome and another is process variation. So we discussed how we can use in the process variation with that biochemistry data. We will discuss process variation also. See, what we have to do, we have to develop little change in our habit. everyone feel very happy when they don't have to do hard work. We have to motivate ourselves for this hard work. Everybody likes this pizza, burger, chips, cool drink, etc. But to maintain good health, we have to switch to fruits, which is not easy. But if we change our habits, then after some time we feel happy. Yes, we have achieved something. Same is true for our laboratory. In the beginning, you will find, oh, this is little expenditure on us. We have to get our equipments calibrated. Oh, we have to run control once a day or twice a day or two times, two level control. Oh, this is so much extra expenditure on us. But ultimately, in long run, these things give better reputation to the laboratory, better patient turnover, better revenue. One thing is Six Sigma. Another is lean concept. I showed you one data. So now we are discussing some theoretical part, then I will show you another data. See, lean concept means what is the difference between fat and lean person? In lean person, extra fat is not there. Otherwise, same body organs, same soul, both are enjoying life in different way. But if somebody has to climb stairs, 100 stairs, so it is easier for lean person to climb those. So what is the meaning of lean concept here? We are removing wasteful expenditure. We are removing extra waste from our laboratory. So what will happen when we remove extra waste? Suppose we are reducing this venipuncture failure. The number of venipuncture failure per given possibilities, that will decrease. So it will lead to increase in the Six Sigma. So now when waste is not there, our reagents are not used in the unnecessary tests, there is increase in the productivity, more acceptability by the consumer, and ultimately better reputation of the laboratory. Our repetition of the test will be reduced. We have to maintain little less inventory because our wastage we have reduced. We will be able to reduce our turnaround time, because otherwise, if we have to repeat the test, it takes additional time. Our analytical time is also decreased. Now see, previously we discussed process variation. So now we will discuss process outcome. See how we can apply Six Sigma in this. Same situation, the same time period, we collected 16,562 samples in this 6-month period. Number of hemolyzed samples were 6, number of venipuncture failure was 7, number of clotted EDTA blood were 29. The total number of errors were 22. We calculated the percentage defect. Percentage defect means unacceptable situation. And if we subtract these from the 100, we get percentage yield. The number of defect per million opportunity, and with that sigma table, we can get the sigma value. So these are the sigma values in different situations. The total number of errors 22, 4.5, 4.9, 4.8, 4.7, something like that. And what were the reasons for failure? We analyzed One thing may be improper training or poor mixing of sample or too vigorous mixing, which is causing hemolysis, or samples are not stored properly. Samples are not stored properly. So these were the reasons. For that, what was required? Training and post-training evaluation. What type of training? How to collect sample, how to mix the sample, how a coagulation tube sample shall be mixed, not too vigorously, not too lightly, how many times tube shall be inverted and then again bringing to same position. For EDTA, for hemogram, how the sample shall be mixed, how the sample shall be stored, proper training and post-training evaluation also we are checking whether they have understood the concepts or not. So we developed action plan. We will develop a regular training system and we will also evaluate competence. Competence means ability to use acquired knowledge and skill in a practical situation. We have conducted training, post-training evaluation also. At the time of training, we are asking them to carry out that activity. And then in practical situation, how they are performing, whether they are able to perform in a required manner or not in practical situation. Environmental monitoring, if suppose temperature is very high, because we have seen in many laboratories, they are collecting samples without AC. In summer, June, July, because of excess heat, the sample may get hemolyzed. And we thought we will again evaluate 6 sigma after 6 months. And our aim is to achieve, we are close to 5, our aim is to achieve 6 sigma above 5 in these pre-analytical situations. So how it is evaluated? First, we have to define what is the problem we are facing. What is the problem we are facing? We can define the problem as unacceptable samples. Situation may be any. Then we have to measure how many times situation is unacceptable. Then we have to analyze. In these cases, there is venipuncture failure. In these cases, clot in the blood. In these cases, samples were hemolyzed. Then how we can improve this situation? What is the action required? Then evaluate over a period of time, whatever methodology you have developed, whether it is bringing some results or not. Define, measure, analyze, improve, and control. This is called DMAC. Then there are steps in each of this situation. In case of define phase, when you're defining some problem, like here, identify and state the practical problem, we have to understand what our customers, like doctors who are sending us samples, patients who are providing samples, staff, what exactly they are saying and what is their requirement. And also find out the areas where we can apply this Six Sigma, whether it is process outcome or process variation. As I said, waiting time in the lobby. You want to see what are the instances when patient had to wait for more than 30 minutes. So that way, we are defining what are unacceptable situation. Then you're measuring, you're collecting data, and then you're finding out what is required. If it is some qualitative things, process outcome, or in certain quantitative also process outcome. And in case of your whatever you are carrying out regularly, like your testing of quantitative parameter, process variation. You are measuring, and after that analyzing. What are the reasons? If sample is unacceptable, what are the possibilities? What are the different type of unacceptable samples? And what are the factors responsible for that? Now you are deciding how I can improve in this situation. What are the actions required? Suppose there is hemolysis of sample, temperature is not maintained. What is the reason? Very high temperature, which is affecting our result. Okay, we need AC and monitoring of temperature also. So that, and then keep watch on that. Every month you are analyzing temperature data of the sample collection area. Then how samples are transported from sample collection area to laboratory. Whether these are with ice pack or not, if temperature is affecting. And we have to use not only spatial senses, sometimes common sense is required. If suppose you are operating a lab in Jaisalmer or Jodhpur, where very high temperature is there, this ice pack, etc., all these things are important. Temperature monitoring is very important. But if you are running a laboratory in Leh Ladakh, temperature is maintained. There is no use of ice pack there. You have to be little practical. What is the solution required in a particular situation? In area, you may get some area, you may get temperature 45, 46. You have to use AC in the laboratory. In certain area, you may get temperature -5, -10. There you may require some heating system so that optimum temperature 20 to 22 is maintained. It is not only AC, it is the appropriate maintenance of temperature. We are discussing quality in global terms, not only for our area, in global terms. See, these are the different type of wastes we may get in our laboratory. Incorrect data entry, overproduction, extra reports are not kept properly. Some patient is coming, then we are printing second time, or we are sending one copy to treating doctor, one copy to ward, one copy we are storing in our lab. We can keep soft copy also. In transportation, extra steps, waiting for the billing, for sample collection, report dispatch. In inventory, certain kits are going expired. That way, travel from report dispatch to lab or wards to lab, how samples are transported, processing, non-utilized talent. All these things, you can say waste in laboratory. One person can carry out 2-3 activities, but certain things we are saying no, this person will carry out only this activity, this person will carry out only this activity, the non-utilized talent. In conclusion, what we can say, Six Sigma helps in developing appropriate QC strategy and also cost savings and resource management. We have to understand how we can apply this in different situations. And this is helpful for hospitals also because it was started in Motorola. Then General Motors, they propagated this concept of Six Sigma. So in our healthcare system, in our laboratory system, understanding of Six Sigma is a little less. People think it is something which is very complicated, but this is not complicated. You can understand whatever we are discussing this 1 hour, it is not complicated. We can manage our resources in a better way. So whenever I get the opportunity to speak on anything related to quality, I always tend to include measurement uncertainty also in our discussion. Because I always find lot of uncertainty regarding the understanding of this measurement uncertainty. See, we have to understand how much variation is possible in our laboratory in relation to a particular analyte. If variation in controls is high, you will get more variation in patient result. If variation is low in controls, you will get low variation in the patient result. This concept of measurement uncertainty can be applied only to quantitative parameters, not to qualitative parameter. How we detect variation based on standard deviation or CV percentage. If you recall your knowledge of statistics, which you read in Park and Park, although that is not the concept of preventive social medicine, but we read this in Park and Park. One standard deviation covers 68.3% data points. Two standard deviation covers 95.5% data points. And three standard deviation covers 99.7% data points. And again, if you recall, we also read 95% coverage is adequate representation of any data. For biological reference interval also, we take central 95%. If we apply that knowledge, suppose a neonatal bilirubin, high level bilirubin control is SD is 0.2. If we multiply that by 2 standard deviation means 95.5. If we multiply that by 2, we will get 0.4. Right? So this is measurement uncertainty. In books, you will get, they say multiplication factor 1.96. Why they say 1.96? 2 standard deviation is covering 95.5%. So 95% is covered by 1.96. That is why they say. Otherwise, hardly there is any difference if you are multiplying something by 1.96 or you are multiplying by 2. So now, what is the practical utility of this concept? Anyone from the biochemistry department? Please write in the chat box. Anyone from the biochemistry department or from the pathology who is reporting biochemistry also? fast, because it is already 1. No one. I will not ask any question. Dr. Yogita, please unmute yourself.
Sir,
Yes. Dr. Yogita, what is your specialty?
pathology, sir.
Pathology. Are you reporting biochemistry also?
Yes, sir.
Okay. See, if suppose you are reporting a neonatal bilirubin 22.4,
Yes, sir.
and now clinician is calling you, madam, you are saying it is 22.4, and I have to decide about exchange transfusion at 23.
Yes, sir.
The situation is very critical. If I decide on the basis of your report, I am not performing this exchange transfusion and actual bilirubin is more than 23, bilirubin may cross blood-brain barrier. It will be deposited in the basal ganglia, connectors, and ultimately severe mental retardation.
Yes, sir.
If I am deciding exchange based on my clinical acumen, and if something happens because this preterm neonate, they are more prone to septicemia, etc., because of this intervention.
Yes.
I don't have any biochemical support with me. Why I perform that exchange transfusion with 22.4? So, are you sure this is not more than 23? What will be your answer?
Sir, when the value is high, we usually repeat the test twice already before
Now,
talking to
suppose
the
you
physician.
have repeated. Now it is 22.5. What will be
Okay,
your
sir.
response now? As clinician is asking the same question.
Then my value will be the same, sir. 22.5.
So now what will be your answer to him?
That is his decision, sir, finally.
No, but he wants your support.
Yes, sir. We can repeat, we can get a fresh sample and repeat otherwise.
See practical situation.
Hmm.
You have reported a bilirubin as 22.4.
Yes,
So
sir.
now, when the clinician is calling you, now you are saying all these things. And this is emergency situation. See, in the first week of life, we write life of the neonate in terms of hours. Up to 168, it is written as hours, up to 7 days. 82
Yes, sir.
hours, 68 hours, 84 hours, like that. See, if we develop little objectivity in our system, as we were discussing during 6 discussion, if we bring little objectivity in this, we explain them. Or we can have a session on measurement uncertainty separately for our clinician, and then they will also understand. We tell them, see, when we are running controls, we get some variation. This
Yes, sir.
is inherent to our measurement process. And you also know this, you have also read this Park and Park, key 2 standard deviation covers 95.5% data proposition, right?
Yes, sir. Yes.
On the basis of our control result, standard deviation is 0.2 in our control. And
Yes, sir.
measurement uncertainty is 0.4, 0.2 multiplied by 2. So whatever we are reporting, if it is 22.4, we can tell you with 95% certainty, it is not beyond 23. This
Yes, sir.
we can tell you with 95% certainty. It is better you keep this neonate under phototherapy and
Yes.
then repeat sample after 3 hours, 4 hours.
Okay.
Based on this value, we can tell you this much. If it is very low birth weight baby, then you use your clinical acumen, what you want to decide. But this is the basis of our concept Why we are saying we can tell you with 95% certainty, this is the reason. Now suppose after 3 hours, they are sending you sample again. Now it is 22.8. So now he will not ask you, oh, they have also already explained the concept. Child was on phototherapy, still the bilirubin has progressed. Now consider the same concept of measurement uncertainty. It may be more than 23.
Yes, sir.
They will not ask anything. They will directly go for the exchange. And they will understand whatever these laboratory people they say, they have some scientific concept behind that. Right?
Yes, sir.
It is not there. Because if they will ask from another person in your laboratory, if all of you have the knowledge of this measurement uncertainty, everyone will speak the same thing. So this gives more confidence to the clinician. There is no subjectivity. Whatever they are saying, they have some reason behind that.
Yes, sir.
So, Dr. Yogita, where are you from?
Hyderabad, sir.
Hyderabad. Which institute?
Redcliffe Lab, sir.
Radcliffe Lab. Right. Okay, good. Okay, similarly, anyone who is from the microbiology department. Anyone from microbiology? Because although we use this for quantitative results, but in microbiology also it has some use. No one from microbiology. I will not ask any question. I just want to discuss a situation. अच्छा जी, अंजन त्रिवेदी. Yes, Anjan Trivedi, unmute yourself.
Yes, sir.
So, Anjan, I think you already know the concept of this measurement uncertainty in relation to microbiology. See, in serological tests, you are not reporting the measured value, but you are measuring something as an intermediate step. You are measuring absorbance, then you are checking with the cutoff value. If it is less than cutoff value, you're saying it is negative. It is more than cutoff value, you're saying it is positive. Am I right, Anjan?
Sir.
Am I right?
Sir.
Now, if you are suppose running controls, positive controls, 1.22, 1.18, 1.23, so you can, when you are getting some variation, you can calculate standard deviation also. If you multiply that standard deviation by 2, you will get measurement uncertainty. Now suppose your cutoff value is 1. Standard deviation is 0.1 and measurement uncertainty 0.2. Suppose in a patient, absorbance is 0.6. If you add this 0.2 in it, it is 0.8. Still it is negative. You can report that with confidence it is clearly negative. But suppose your absorbance is 0.9. It is less than 1, negative. But if you consider measurement uncertainty, 0.9 plus 0.2, 1.1. It can be positive also. Similarly, a positive result may be negative. So here you have to report with caution, with the explanatory note. See, this is in the borderline range. Get this repeated after 1 week or 10 days, whatever you want to say. Generally, serological test gets settled in one direction by this time. And they will not send to some other laboratory to repeat the test. They will send after 1 week or 10 days to your laboratory, and then you will get the clear answer. Otherwise, what happens? One day they are sending report to sample to one laboratory, they are saying it is positive. Next day to other laboratory, they are saying it is negative. And then clinician is fighting with both the laboratory, patient is fighting with both the laboratory and fighting with the clinician. You are just wasting our money. And both laboratory, they are fighting with their company people. Because of poor performance of your machine, we are losing reputation. Am I right?
Sir. Yes, sir.
So, to avoid all these
Yes,
things, what is required? We should know the concept of this measurement uncertainty. The thing is, if you know these quality concepts, ultimately, this will give you peace of mind. This will give you more confidence in dealing with any situation. You will get more satisfied customers. Thank you very much for your patience listening to this little complicated topic, although I tried to simplify as much as possible. Dr. Ashok Ratan sir, please unmute yourself. We want to
Yes.
listen your golden words. You are with us.
It's very nice. Thank you. I think for the first, I've been trying to struggle with understanding Six Sigma for a long time. And I think today it became clearer about how to use it. Of course, as you know, Six Sigma would be very useful for within the lab. People have used it even for pre-analytical, but within the lab, most of the new equipment claim to say that they are Six Sigma. And Six Sigma means that you don't have to repeat. While most of the labs work at 4 Sigma, that means they waste 20 to 30% of their profit in repeats.
Yes, sir.
So if we can make sure that all our equipment are functioning well, and within the they are 5 to 6 Sigma, then we will make more profit because we don't have to then keep on repeating the tests. But of course, the Achilles heel in our setup is the pre-analytical. And I think once we have everything under control within the lab, then we all will focus on pre-analytical. And once pre-analytical is under control, then we'll have excellent lab work.
Yes, sir.
But it was an excellent session. Thank you very much.
Yes, sir. Thank you, sir. Dr. Sunita Deshmukh, ma'am, please unmute yourself.
Yeah, yes, Dr. Jain. We were talking about SD plus 2.
SD multiplied by 2.
SD multiplied by 2. Is it SD multiplied by 2 or CV multiplied by 2?
It is the same thing. It is the same thing. See, if you are multiplying by SD, then it is easier to calculate. Because what happens, why NABL say CV multiplied by 2? Because they are asking in the scope. They are not discussing the utility of this measurement uncertainty. They are asking to document measurement uncertainty in the scope. So you are multiplying by CV and you are just mentioning there. But here we are discussing practical application of this measurement uncertainty. Suppose you are reporting platelet, 48,000. And in low level control, your standard deviation is 1,000. What will be the measurement uncertainty? 2,000. You are saying whatever you are reporting as 48,000, it is between 46,000 to 50,000.
Correct.
Now suppose you are using CV%. Your CV is suppose 1.5%.
Yeah.
The measurement uncertainty 3%. Now 48,000. How much variation is possible? Now you are calculating 3% of this 48,000. Then you are adding in this 48, subtracting in so this will unnecessarily complicate the calculations.
Okay.
For practical application, SD is better. And for just to mention in the scope of accreditation body, because you are already calculating CV and mentioning there, so it is percentage.
Okay, now I understood. Okay, here we have to calculate percentage, and then we have to calculate the percentage from the result also.
Yeah.
So it is easier to do it from SD. Right.
Yes.
Thank you.
Right.
Thank you.
Okay. Right. Thank you very much. So now you will get the certificate in today is Saturday, by Wednesday. And you have already filled the attendance link. If some of you have not filled the attendance link, we are keeping this for open for 5 minutes. Please fill the attendance link and the feedback. Thank you very much.